My name is Dana Goldman. I'm the director of the Schaeffer Center for Health Policy and Economics at the Price School of Public Policy and the School of Pharmacy. And on behalf of the two schools, as well as the Schaeffer Center and the Brookings Institution in Washington, D.C., I'm happy to welcome you to this really important discussion about universal coverage and the challenges associated with it. Some of you may have seen today that the price of a premium for a family plan is now exceeding $20,000 a year. And, you know, one option to deal with this is we sometimes ask, why is it that Kaiser doesn't, if you look back 15 years ago, it was about half as much. And why doesn't a company like Kaiser say, hey, I'm going to offer an insurance policy and we'll treat everyone the way we did 15 years ago, and it'll be half the premium. But when you ask people, they say, would I take half the price and half the care? They say, no, I don't want it. I prefer today's health care at today's prices. And so the challenge we face is one, as we worry about affordability, how do we preserve what people really value in the health care system while making sure that we can provide access for everyone? And I can't think of a better program to address these challenges, and I'm looking forward to a very fulsome discussion. We're really honored to have the California's Attorney General, Xavier Becerra, with us. And after the remarks, the Attorney General will talk with Professor Paul Ginsberg, who leads our USC-Brookings Schaeffer Initiative for Health Policy. And then during the second half of the program, I will be moderating a panel with our Brookings colleagues who were gracious enough to come out and spend time with us. And so with that, I'd like to get started right into the program and introduce Leonard Schaeffer, the Judge Robert McClay Whitney Chair at USC. Mr. Schaeffer, as many of you know, is actually uniquely situated to talk about this issue because he ran Medicare and Medicaid. He ran WellPoint and built WellPoint as its founding chairman and CEO, and knows how to solve all the problems, and we're hoping he'll share that with us at some point. So please join me in welcoming Mr. Schaeffer.
Well, thank you very much, and thank all of you for being here today. I want to welcome you. We have an administrative issue that is a little embarrassing, which is that if you look at all of this material, my name is only mentioned 3 times. So I hope someone will work on that. We are very grateful and gratified to have the Attorney General of the state of California, Xavier Becerra, with us today. And he is a person who has accomplished a great deal in a relatively short period of time. He is the first Latino Attorney General in the history of California. Previously, though, when I got to know him, he was in Congress where he served 12 terms in the House of Representatives. He was the first Latino to serve as a member of the Ways and Means Committee. He became the ranking member of the Ways and Means Subcommittee on Social Security, and he was chair of the House Democratic Caucus. He has served the people of California in a number of important ways, including a focus on strengthening Social Security and Medicare, and I think we'll hear echoes of that today. He's also focused on the challenges of poverty and has been the champion or a champion of improving the economy generally and here in the state to generate more jobs for people and to promote such industries as healthcare, clean energy, technology, and entertainment. Javier is a native of the state of California, something that I run into fairly rarely. I don't know about the rest of you. He is the son, in his biography it says, of working-class parents. He was the first in his family to receive a 4-year degree, and he earned a BA and a law degree at Stanford, which I assume is a function of not being able to get into USC. But you got to do what you got. I went to Princeton. I couldn't get into USC either. Okay. I was very surprised, frankly, when Javier left Congress to return to California, because he was clearly on his way to leadership. But I think all of us, if we are Californians, and all of us, if we care about certain things, are very fortunate that he is back in California doing an outstanding job as Attorney General. Particularly his challenges of the efforts by the federal government to limit health care funding. He's targeted anti-competitive practices and defending democracy, I think, is what's going on. He has also led coalitions of states' attorneys general who share his goals, and I think hopefully we'll see the courts help us out. So, for him and for all of us, today's topic of discussion is critical, and we are grateful and happy to have the Attorney General with us. Please welcome.
Leonard, always great to be with you. Thank you for everything you do, continue to do. Thank you for taking an interest in not just healthcare, but in how California does it, so we can do it better. You're sitting next to someone, Tom Prisolak, who's a dear friend as well, and a champion in healthcare for a long time, and runs one of the major healthcare institutions in America at Cedars-Sinai. And thrilled to see Tom here with us, because he probably knows as much, if not more, than pretty much anybody in this room when it comes to healthcare. Let me do this. I'm going to try to keep my remarks a little brief, because I'm an enforcer these days, not a policymaker. And so it's a little different. I can tell you about the actions we've been taking, and I'll mention maybe a couple of them. But really the discussion, if we're talking about moving on this path toward universal coverage, there are two things that strike me. First, universal health care in America. We're still trying to get there. We still treat in America healthcare as a commodity, something you could buy in a marketplace. And if you have enough money, you can buy the better version of it. And if you don't, you go shop at the Goodwill store and see if you can find it there. I don't think there's an American who treats the question about whether his or her child should be taken to the hospital when a major condition erupts like a commodity. You're not going to take your child to Goodwill when you need to have an emergency operation. And that's why perhaps, Leonard, no one would want to see healthcare 15 years ago at 15-year-ago prices be the healthcare that we get now. Everyone always wants to get better, because healthcare is not a commodity. It should be something every one of us knows that we can offer to our most dearest and loved members of the family. But here's the flip side of that. Healthcare is not a right in this country. It's still a privilege. And the more money you have, the more of it you get. And so only in America, where we are by far the economic and military power of the world, could we wonder how it is that we're still today wondering how we get to universal health care coverage. That pains me as an enforcer of our laws and regulations to say, because it seems embarrassing in this country of riches that we still speak of healthcare as a commodity that is a privilege to access. Only in America. At the same time, only in America could a kid who grew up with a father who had a 6th grade education and a mother who didn't come to this country till she was 18 have a chance to be the first in his family to go to college, get a degree, and now get to enforce the healthcare rights of 40 million people in the state of California. Only in America. And so I choose to look at the only in America that is doing things the right way and believe that that part of America is going to push us quicker to doing things the right way for everyone, including when it comes to universal health care coverage. And so then let me focus, and I've got some remarks that I can look at, but I know this too well. Mention a couple of things I'd like you to know. There's a guy named Roy Spence who's from Texas. He's a wordsmith. He's a media communicator. He's the guy that came up with the slogan. I think he's the guy that came up with the slogan, what happens in Vegas stays in Vegas. I heard him say once, I've got it right, if you're going to lead, never do mild. Never do mild. I think of America's dreamers, the population of young men and women who don't have documents to be in this country but have come out and said, here we are, we're going to prove ourselves worthy of being in this country. Their slogan is undocumented and unafraid. Never do mild. This is not a time in America for us to do mild. Not when it costs so much to have health care, and we're fighting so hard to keep the little we've got in the Affordable Care Act. Never do mild. And so my point is this. When someone says we should fight for Medicare for all, for the life of me, I don't understand why there are people who get spooked by that. There are 45 million people in America who today would say, this Medicare card, keep your stinking government hands off my Medicare. And for the folks that didn't get that, Medicare is a government-financed program. There are some 80 million people who depend on our government to have access to health care through Medicaid. The millions of veterans in this country depend on the Veterans Administration to provide them with, by the way, the closest version to single payer that we have in America. And with the Affordable Care Act, subsidized through taxpayers, through our government, another 20 million Americans get their health care. And those of us here who might have a pre-existing condition depend on the Affordable Care Act to make sure that we don't get discriminated against by insurance companies. And so how can it be when we hear a discussion about Medicare for all that somehow that's distorted into a bad thing? I haven't yet heard one of the 45 million seniors say, absolutely, I want to trash my Medicare and go into that private insurance marketplace. And so I would just hope that what Americans would do is recognize that this is not a time to do it mildly. And if you believe that we should have universal coverage, then get out there and fight. If you believe that Medicare has served Americans in this country well for more than 50 years, then we need to get out there and fight. Because we've got to get to the point where healthcare is no longer a privilege, where we treat it like a commodity. Because until then, we're really not fulfilling our true role as the most dynamic country in the world. And here I'll close by saying one final thing. I love this country. It has offered me, the chance to be the Attorney General. I dare say if my parents had remained in Mexico, their son would have had that opportunity. But I'm prouder of the fact that I also am a resident and a defender of the state of California, because we do things a little bit different in the state. And that's why, even though we're a high-cost state, we still have lower costs per capita for health care than the rest of the nation. That's why, even though we're a high-cost state, we still have become the economic engine for the rest of the country, creating more jobs than any other state in the nation. That's why we can say that we are number one in clean energy at the same time that we're number one in manufacturing. We can say we're number one in high technology, at the same time we can say we're number one in agriculture. We're number one in hospitality, tourism, just as we're number one when it comes to entertainment. We graduate more people from institutions like USC than any other state in the nation. And we just nudged Great Britain to the side last year and became the 5th largest economy in the world by ourselves. And so why should we do things differently? In California, we're moving to provide universal coverage to everyone. Everyone. Not there yet, but we're trying. We're not trying to abolish the Affordable Care Act. We're not trying to shortchange Medicaid. We're not trying to spook people about what Medicare is. And so I hope that the rest of the country learns from California, because we are doing something a little bit differently. I am proud to be a Californian. I'm proud to be an American. But I will tell you more importantly, I'm proud that all of those folks who gave my parents a little bit of a hand to help pay for that education, which costs about as much as USC's education at Stanford, I now have a chance to prove to them that they made a good investment. And we are going to fight in California to make sure we do the same thing for others, because healthcare should not be a privilege. And we should not let anyone, and this Attorney General will not let anyone treat healthcare as a commodity. And if we can get there, I guarantee you, we will be at universal coverage really fast. Thank you.
Got some follow-up questions. First, I'm Paul Ginsberg. I'm professor of health policy at the Price School and the Leonard Schaeffer Chair in Health Policy Studies at the Brookings Institution. And I direct the USC-Brookings Schaeffer Initiative for Health Policy. So California and other states have been involved in various lawsuits related to the ACA, and most prominently, you've joined the Texas versus U.S. litigation, in which Texas is asserting that the ACA is unconstitutional, and California and other states are arguing in defense of the ACA. Can you reflect on what you think this flurry of state-led litigation means for ongoing state and federal partnerships on healthcare policy?
Well, the partnerships have to continue. We can't do anything without working together with our federal partners throughout the country. But sometimes they get it wrong. And in the case of the Affordable Care Act, after more than 70 attempts to try to repeal the Affordable Care Act, that failed. And after at least one Supreme Court decision which upheld the constitutionality of the Affordable Care Act, we're now at it again. Now in the Fifth Circuit, likely on our way to the Supreme Court. California is the lead attorney defending that case, because the federal government, which has the responsibility at the U.S. Department of Justice to defend federal laws, decided to go AWOL. So we stepped in, understanding that we could not expect the Trump administration to defend the Affordable Care Act. And so today, California, along with some 20 other states, are defending the Affordable Care Act in court.
If the ACA should happen to be overturned by the Supreme Court, what would be California's options?
So I don't think it's going to be overturned. First, let's start there. We're arguing the case, so why would we lose? Secondly, as I said, we're on this march toward universal coverage. If we can't get past even the point where someone who has a child born with a pre-existing condition, or a child with asthma, can't be guaranteed insurance coverage because of that pre-existing condition, then we're in real trouble. That is not the America that I grew up believing in. And so I just don't believe that there are 5 justices on the U.S. Supreme Court who believe that because Congress in 2017, at the very end of the year in December, passed a tax measure which essentially zeroed out the amount of tax that would be paid in the individual mandate of the Affordable Care Act, that was meant to mean that the entire Affordable Care Act as a statute would be abolished. Never once will you find in the tax legislation that became law in December 2017 a word that says that the Affordable Care Act shall be repealed. And so simply because you zeroed out the account that someone must pay through a tax, the individual mandate tax, if you decide not to purchase a policy of insurance, so you're showing responsibility, it is very a long stretch to say that that's the basis to say that constitutionally we must repeal the entire Affordable Care Act, including the prohibition against discriminating for pre-existing conditions, the enhanced Medicare coverage for seniors to be able to have preventative care visits without co-pays, the ability for parents to keep their kids on their insurance plan until their kids turn 26, or the expansion of Medicaid to millions of Americans so that the states could afford to help subsidize healthcare for so many people. I just don't see it. But then again, I've seen stranger things these last 2.5 years.
Thank you. You've been very active as California Attorney General in addressing high provider prices, especially hospital prices, through antitrust litigation. Are you seeing increasing attention to healthcare prices by attorneys generals in other states?
Yeah, actually, I can now talk about what I'm actually doing now as Attorney General versus when I was in Congress. We filed a lawsuit against the largest healthcare system in Northern California, Sutter Health. Sutter Health is the big dog in Northern California. We allege in our lawsuit that's going to trial in about a month that Sutter Health is driving up prices because it's using its market power to control prices. If you try to go into a hospital here in Southern California for, you name it, heart attack, there's a good chance that same condition, same circumstance, but now in Northern California, you will pay 30 to 40% more for the cost of the health care services you receive to treat that heart attack, holding everything else constant. There's no explanation except that the market there in Northern California is less competitive. And we are taking on Sutter Health under an antitrust suit, claiming that they are driving up prices by controlling the market. That case is being watched all over the country because we've seen a lot of consolidation recently in this country. Some of it driven by the Affordable Care Act, because the Affordable Care Act tries to drive efficiency into the system. But you get to the point where you go overboard and it's no longer efficient. It may be efficient for your bottom line and your profits, but it's not efficient for consumers. We're also taking on the pharmaceutical industry because there's a practice that's grown dramatically in this country where brand name pharmaceuticals, J&J and you name them, they have a habit of suing the generic companies, claiming that the generics are trying to muscle in on their patent and sell their version of their drug for less because it's a generic version and they're using essentially the work that was done by J&J and the brand name company to develop and then market these pharmaceuticals. But what's happened is that lawsuit, that legal right to sue to protect your patent, has become the backdoor way for, and legally for, a company, a brand name company, to close the doors in the back room and say to the generic, hey, by the way, how about if we do this? My patent's going to run in about a year. How about if I give you some money? I'll give you a cut of my share of the profits over the next 5 years for my pharmaceutical. Even though after 1 year you'll be able to market your own drug, don't worry. Sit back. You don't have to do anything. We'll pay you not to do anything. We'll pay you to delay putting out the generic version of our drug, which means we continue to be the sole monopoly that can sell that drug at a very high price, and it doesn't hurt them to give a little cut of their profits to the generic who just sits back, doesn't have to do anything, and collects money. Payfordelay, that's what it's called. We recently sued a few pharmaceuticals. We got them to give us $80 million for what they say they did. They say they did nothing wrong. So they gave us $80 million for doing nothing wrong. And we are trying to do what we can to undo these types of deals because it is not right to use a legitimate legal process, the courts, to use the secrecy, that's the confidentiality that's allowed through a court settlement, to do these backroom deals that in the light of day would be considered antitrust violations.
Yeah. To what extent has been the increased activity in California and other states a response to inadequate federal activity in antitrust and healthcare?
Gosh, okay, well, good thing we're limiting ourselves to healthcare, because we talk about the environment, we could talk about immigration, we could talk about a number of things. I mean, first and foremost, the fact that this administration has tried to undermine the Affordable Care Act for 2.5 years, even to the extent of killing the budget for advertising during open enrollment for the Affordable Care Act at the end of the year, when people usually try to get information about what they can do. They essentially squeeze the money out of the budget to try to do communication to give people information about that. So everything from that to right now, we're in court against this administration for trying to deny women under the Affordable Care Act access to birth control coverage, which they are entitled to under the Affordable Care Act. We are fighting the administration on Title X, funding for family planning services. And many of you know that in California, Planned Parenthood has now stopped providing some of those family planning services because of the so-called gag rule that would prohibit them from providing many of the services that they're there for in order for them to receive some federal funds. We have taken this administration on in other areas, making sure that facilities provide transgender individuals with the healthcare services they should be entitled to. I could go on and on.
Okay. In situations where the providers are already consolidated, like in Northern California, what are some of the most effective remedies to address that? And for example, if you succeed in the case against Sutter, what are the remedies that you have in mind?
So the best remedy for all these things is always sunshine, right? It's the best disinfectant, as they say. And the more that there's transparency, the less likely these companies will engage in these anti-competitive, deceptive activities. And so we're trying to get them to open up their books a bit more so they show how they do their book of practice. We're also trying to make sure that they don't conspire to have arrangements where they can force those who have to purchase their services, whether it's the insurance company that's trying to purchase access to hospitals and other healthcare facilities to offer their insurance clients, or whether it's consumers directly, where if you only need a certain product, there's no reason why you should be forced to buy a whole series of other products. So Sutter essentially tells insurance companies, employer, healthcare providers, that if you want access to our flagship hospital, you've also got to pay us to have access to all these other healthcare facilities that we've got, even though you don't expect to use those. So of course that costs money. We want to make sure that we don't let them use their market power and their ability to snuff out other competitors so that at the end of the day, the benefits inure to the consumer.
Yeah, so in a sense, a series of rules that ban practices which get in the way of competition.
That's right. Yeah, the consolidation for purposes of efficiency could have value. But again, if we allowed sunshine on some of these practices, we'd see really if they were done for efficiency or not.
Yes, I know that in Congress, the Senate Health Committee reported legislation that includes some of those same approaches, so maybe you've inspired them. If you prevail on your suits against...
When we prevail.
Excuse me, when you prevail. Actually, I guess you already settled. I was thinking in the Payfordelay. To what extent might actions of California and other states which are challenging that have a national impact?
Oh, it will have a national impact. We were fortunate because we were able to persuade a number of legislators in Sacramento of the scourge of these pay-for-delay agreements. We were able to pass legislation this year that's now sitting on the governor's desk that would require the pharmaceuticals to have a more open process in filing these patent dispute lawsuits. And while it doesn't prohibit the practice, it makes it a little tougher. It's the transparency. It's the open the doors policy. And so we're hoping that we'll have a little easier time making our case. These are very expensive cases, and as you can imagine, these pharmaceuticals come at you with a lot.
Good. Last week we saw a report from the Healthcare Cost Institute that hospital consolidation in urban markets continues to increase. There seems to be somewhat of a bipartisan consensus to address consolidation by taking steps to foster market competition, but concrete legislative initiatives encounter substantial resistance from stakeholders. So the question is, might we be approaching a point where policymakers lose patience with competition and opt to pursue price regulation or rely more on public insurance programs?
So, and this is probably a question where Tom Prisolak or Leonard Schaeffer, who've got years of experience directly on this, could answer better than I can. Here's the way I'll try to respond to that. You have a system in place. It essentially tells those who wish to get into the business of healthcare what they have to do. And there are a lot of regulations on any type of healthcare provider, whether you're the hospital or whether you're the health insurance company or you're a third-party type of provider, medicinal, newer types of treatments. You look for the way that you can survive in this business because it is a business. And so part of it is trying to extract efficiencies in the way you do your work, your business. Sometimes it's by trying to leverage out some of your competitors so it's not as difficult to make a buck. It is a very competitive business. And so you can't blame folks for trying to make a buck and survive. There are any number of businesses, whether it's a hospital, a nursing home, chiropractor's office, they will tell you how tough it is sometimes to survive. When you've got to always worry about what Wall Street will think about your quarterly return, you're always going to have to figure out a way to extract more from the payer. I just don't think in healthcare that's a smart way to do business because, as I said, Americans don't think about sending their kids to the Goodwill hospital when it's time to get the best treatment you need to make sure your child comes out of that hospital better than when you took her in. You always hear, people will say, I don't care what it costs, do it. And that's the way it should be. We should want the best for our loved ones. That never works well when you're confronting someone who's trying to figure out how to make a buck. Someone who's desperate saying, I don't care what it's going to cost, do it. Someone who's trying to figure out how to stay alive, okay, we'll do it, and maybe we'll do a little bit more, or maybe we'll figure out how to extract a little bit more from you. Why else should any surgery cost 10 times more in one facility than it does in another? Everyone's trying to figure out how to game the system so they can end up surviving. And so what I would say, Dr. Ginsburg, is that in the marketplace that we have for healthcare, you're going to have some of these abnormalities. And it's always going to be a matter of trying to hunt them down and do the oversight to prevent it. Or, as you said, maybe go towards a more compliance system where you have regulatory price setting, which I think essentially makes a lot of these providers say, I can't make a whole lot of money because it's fixed, the price is fixed. So I'm going to fix what I do. I'm not going to innovate, and you never get quite the best. As I said, I would scrap a lot of that. Maybe Tom Prisolak doesn't want to hear this at Cedars. I would scrap all of that and move us toward a system where everyone has access to health care, a single-payer system, a Medicare for all system, which, by the way, think about it, Medicare has private insurance in it. You don't eliminate private insurance because Medicare doesn't cover all your costs. as a senior. What it does do is it gives you a fundamental level of sustainability and support so that you get at least the most important, the fundamentals of healthcare. You want more? You can get more. That's where the private insurance comes in. That makes it a little easier to make sure that not everyone is gamed as part of this system to acquire healthcare. That means that if you got that Medicare card, whether you're 65 or you're sending your grandchild who is 5, you know that you're going to get a good hospital and good care. You want premium care? Okay, you pay for that above and beyond what Medicare offers you. But we shouldn't have this game where the more you have financially, the more you get health-wise.
As a follow-up to that, in Medicare, is your belief in the single-payer approach as Medicare for all? What are the implications for the Medicare Advantage plans, which now enroll about 1/3 of the Medicare beneficiaries?
It's really interesting because Medicare Advantage is really the insurance company version of Medicare. Medicare offered through insurance plans where they essentially they consolidate their customers and they bill you based on a per capita rate. And so they save money because they'll say, we'll take 1 million patients, pay us $1,000 per patient. We know what we get. We'll try to make sure that we can keep that 1 million population as healthy as possible, so it'll cost us less than the $1,000 we're getting for each one. Or we're going to try to offset how many sick patients we have with really healthy patients. So at the end of the day, on balance, we come out okay at the $1,000 per patient. In many ways, that's what single payer does, is it says everyone in America is entitled to health care. Providers, you're going to get paid, but everybody's going to have access. So you won't be gained by the other institution because everyone will, that consumer, that American will have access to any facility because they've got that Medicare card and they go anywhere they want. And those providers, doctors, hospitals, know they're going to get paid because they've got the backing of the most secure financer in the world, the United States Treasury. I think this, if we're going to treat healthcare as a commodity, then what I've just talked about won't apply. Because let me ask you, when was the last time we treated education as a commodity that maybe your children can afford to have, depending on how much money they have? Well, actually, we've seen some stories that call that into question. But utilities, when was the last time you heard that we allowed utilities to decide who to offer electricity to or natural gas to based on how much they could pay? Think about the U.S. Mail Service, the Postal Service. The reason we have a U.S. Postal Service in the first place is because it became very clear in the 1800s that if you had to pay someone to deliver your letter, they were only going to go to the big cities because they did not have time to go all those little podunk towns all over the country in the transportation systems that we had back then. And so to send a letter to that little town cross country, exorbitant. And so federal government stepped in. There are certain things, whether it's water, utilities, education, mail, really don't lend themselves to be driven by the market because the market would only go where the dollar is. Why is healthcare not among those? Unless you think that you can count on your healthcare based on how many dollars you happen to have in your pocket.
Mr. Attorney General Ed Kleinbard from the law
Good to
school.
see you again, Professor.
It's great to see you. So I myself have become a geezer in the past year or so and carry a Medicare card. And I get a little helpful pamphlet from the Medicare folk every year now to explain my Medicare options. And that little pamphlet is 120 pages long. And I used to think I was a smart fellow, and then I tried to understand it. And so when you talk about Medicare for all, Are you comfortable that Medicare today is working as efficiently and as transparently as you would like?
Leave it to a professor to give you a question that's really tough to answer. And by the way, Professor Kleinbart and I have had a chance to work together on a number of issues. I used on the Ways and Means Committee, so I rely on folks like Ed for great wisdom on tax policy. But I'll tell you, this is what I'll say. Medicare is not perfect. And it has been changed over the years. I was going to use a different word, but change is about as neutral as I can get. Changed over the years, so it's not as simple. And that's because people have wanted Medicare to do all sorts of things. And it's because people don't want to let Medicare go. And so you try to attach more and more to something people don't want to let go. The drug policy, prescription drug access policy under Medicare is crazy. It's crazy. It's not the most efficient way to do it. But seniors were running wild paying for prescription drugs under Medicare. So we had to come up with a solution. We now have Medicare prescription drug coverage under Part D, but it's not the most efficient way to do it. And so, is Medicare perfect? No. Do I want to see us get rid of Medicare? As I said, go talk to 45 million seniors who would say to you right now, Professor Kleinbart, you better run, because we ain't letting you touch. Keep your government hands off of my Medicare. And we can build on it. But here's where I agree with those who say you can't go all the way. We're not going to have single payer overnight. But you got to get to the point where we no longer even challenge the idea of having universal coverage.
Yeah, Joel Hay, Schaeffer Center. So first, quick show of hands. How many Republicans in the room?
It's not that there are actually more, they just don't want to admit it.
Yeah, they might
Sorry about
lose
that.
tenure. They might get fired or something. Anyway, are you aware of the fact that Medicare has a $50 trillion unfunded liability?
I'm aware of the argument.
Medicare Part D, which is what you praised as a program that provides drug insurance to seniors, was passed on a bipartisan basis. There were votes from both Republicans and Democrats. You're advocating single payer, Medicare for all, which is like a left. It's more left than we are now. It's moving in the left direction. The Republicans, whoever's left, I don't know, maybe when they impeach Trump, maybe there won't be any Republicans left, I don't know. But anyway, the Republicans want to go in the opposite direction.
Most Republicans in 2010 were adamantly against the Affordable Care Act. Poll Republicans today where they stand on the Affordable Care Act. And it's not where they were in 2010. Why? Because now they got it. Now they don't have to worry about losing their insurance because they found out they've got diabetes. Or they still got a kid who's under 26 years of age, and that kid hasn't yet found a job that pays enough or has a good healthcare policy attached to the job he or she's getting. All of a sudden now it's, oh, don't take it from me. Keep your stinking hands off of my Medicare. It's the same thing. Secondly, I know you're trying to portray single payer Medicare for all as wingnut left side. Boris Johnson is not a lefty in Great Britain. He is on the right side. He is a wingnut on the right side if you want to call him a wingnut. He is the Prime Minister of Great Britain. Ask Boris Johnson if he's going to try to get rid of single payer in Great Britain. He won't touch it. Why? Because even the conservatives in Great Britain will not allow the Conservative Party to undo their health care because they got it. Now, until you don't have it, or until you have, you don't know what you're missing. And it looks like a boogeyman the way some people describe it. But there is, Japan isn't ruled by, far left party. They got single payer. Germany, Merkel is a conservative. They've got single payer. In fact, you can't find a industrialized nation in this world, conservative or progressive party running it, that doesn't have single payer except the United States. And they all, with single payer, pay less per capita for health care, and they cover everyone in their country, than us, who don't cover everyone in the country. And so I get the stigma, and that's why I said never do mine. I'm not going to do mine. I'm not going to tell you, well, I like Medicare, but I don't like it so much. I sort of like single. No, I will dive on the sword for single payer, because I remember the days when if my dad didn't go to work as a construction worker and get paid through his union, so he'd have union health care, we were out of luck. And when my mom had a miscarriage and was bleeding in our home when we were kids, and we watched her taken away and we had no idea what was going on, my dad didn't have to worry because he happened to have insurance. But most folks who are construction workers, married to a clerical worker, making the kind of money they did, at least today, probably wouldn't have that insurance because there aren't that many union jobs anymore. Call it what you want. We're going to fight, and we were going to get, I guarantee you, in this country, single payer.
John Nelson. I'm a Republican.
You really attract them.
I'll just say some outrageous things here. I didn't vote for either candidate in the last general election. I had some apprehensions about the ACA during the process, and when it passed, in retrospect, I'm fully supportive of it. It was not executed well in terms of its layout, but I see overall the big picture of what it's doing and how all the pieces work. So in some ways, I'm grateful that it's here. In your past life and your current life, past life in the House of Representatives, I'm curious about social determinants and how well known and how well discussed that is. In talking to some friends of mine over at Kaiser, for example, they're donating a tremendous amount of money to house the homeless in Oakland, because it's cheaper to house the homeless in Oakland, having a roof over their head, than having them go and stay in the hospital emergency room for a week and a half.
That's right.
Talking to another insurance company, they are taking somebody every Sunday to church. They drive them to church. Now, that person has no means, no financial means, but in order to make her happy and feel better about life, she wants to be with her friends at church. So they fund her going to church, because if she can have a better outlook on life, the odds are that'll take care of her depression and feel better about things and do more preventive care. So this seems to me something that's really important here that could apply to the 80 to 100 million Americans who are either on Medicaid or have no coverage whatsoever. And I'm wondering if that's discussed in your circles, in your world, how pervasive that is. How does it apply to the commercial sector? How can the commercial sector apply this? Because there's cost shifting going on from the Medicaid, uninsured world into the commercial insured world, so it throws the numbers off and everything else.
John, prescient point. Essentially, as I said before, everyone's shifting costs. I'll let you pay that. I'll save money here. I'll cover this because it's less expensive than to cover that. And everyone tries to shift costs. Medicaid essentially is a cost shifter where we say that these folks can't afford it, so we'll get them Medicaid. We won't give them Medicare level coverage, we'll give them Medicaid. We force hospitals, and Tom can talk about this, to provide charity care. Somebody walks through Tom's hospital doors, he's got to keep that person stable. And you got to do it, because if you don't do it, you can't keep your status as a facility. Lots of cost shifting. I don't see how you totally tackle that in a system that allows, again, healthcare to be treated as a commodity, because everyone's going to avoid the hot potato. No one wants to hold that baby. Everyone wants the wealthy, healthy customer. No one wants the sick, poor customer. There is nobody who will do business that way, right? And you can't get around it. Just the way no FedEx and UPS will never take your business if you live in Shasta, California versus San Francisco or Los Angeles if they have to pay the cost of delivering that 1 ounce letter. And so I just don't see how healthcare accommodates itself to being in a commodity-driven market. But I want to go back to one thing that the gentleman, what was your name, sir? Joel, that Joel mentioned, because there's truth but some not truth in what you mentioned about the unfunded portions of Medicare. You mentioned 50 trillion, was it?
Correct.
Yeah. So that's based on doing a calculation where you say, how much does Medicare cost today? And how much do we take in from the Medicare taxes to cover the cost? The Medicare taxes that you and I pay from our, take a look at your paycheck and the FICA taxes. FICA, part of that goes to Medicare costs. Some of it's Social Security, some of it's Medicare. It doesn't cover the cost of making sure that the 45 million Americans who have Medicare have those costs covered. We're paying for it. We pay for that as taxpayers, right? But it's not funded directly. It's not covered. And so if you add that over the years, it really adds up, especially when you compound the value of those unpaid for costs and the interest of that. It's a massive number. But here's what I'll tell you. If you think 50 trillion or whatever your number was for Medicare, it's even more outrageous for a Department of Defense. Because the Department of Defense, how many of you see a little line item in your paycheck that says tax deduction so we can pay for the defense of this country? There's not a cent that's dedicated to defense. So we're running even bigger trillion upon trillion deficits to maintain the security of this country. Would you say, no way, we should trash our defense, national security, because we don't dedicate monies directly to it? No more. Yeah. Well, yeah, maybe. I voted against the Iraq War, so I tried to save you some money. And so, you know, it's this whole thing. At the end of the day, it's all dollar, it's all cost, and that's the way it should be. I mean, nothing is free in this world, and nor should we expect things for free. But you gotta be in a civilized society. You have to decide what your priorities are. A long time ago, we decided that everyone in America should be able to send and receive a letter for a decent fixed price. Everyone in America should know that their kids can go to a school without having to pay out the nose to have a decent seat in a classroom. Everyone in America should know that they can turn on a faucet and get clean water, although in places like Flint and too many other places now, even then it's a question. But we sort of take that for granted because we accept it. We pay for utilities for a lot of people. We pay for education for a lot of people, but we have benefited. To go to Stanford University, there was no way my parents, it probably cost as much to go to Stanford in 1 year as I think my mom made in a year. There's just no way they could afford to send me to Stanford. You, or maybe more your parents and grandparents, helped pay for my education. I worked every year I was at Stanford. I took out loans. But I got a lot of scholarship money as well. Taxpayers invested in me. I have 3 daughters. Stanford, Yale. I pay full cost, full ride, out of pocket. Well, not me. My wife's a physician. She's the one that really pays. Yeah. But we are paying full freight for 3 daughters. They're actually with the last one is in her last year now. We've paid full. We didn't get 1 cent from the government in assistance in aid. They took out not 1 cent of loan because we didn't want our daughters to be burdened the way my wife and I were with loans. And we made that sacrifice to say they're getting full rides from us. And that's because somebody 30, 40, 50 years ago was smart enough to say, hey, let's let Manuel and Maria Teresa have a chance to get one of their kids into college and be the first in the family to experience walking through the doors of a place like this. They're getting paid back because we as a community have decided to do that. We as a community have to decide whether we want to treat healthcare as something that you and I can afford because we've got the money, but Manuel and Maria Teresa Becerra can only do so if they happen to get lucky and something happens while they're still having union healthcare benefits. It's just not right. And that's why I think ultimately we're going to get to a single payer system, because we're going to get to the point to recognize that healthcare is not a commodity. And it shouldn't be a privilege.
Attorney General Becerra, thank you very much for coming to USC.
Thank you to Professor Ginsburg and the Attorney General for that rather passionate defense of universal coverage offered through single payer. I think we'd like to get to a broader discussion of other ways we might achieve those goals. So I'm going to ask our colleagues from Brookings to come up and give us their remarks, and then we'll have a panel discussion.
Great. I'm Kristin Link-Young. I'm a fellow with the USC-Brookings Schaeffer Initiative for Health Policy, and I'm based at the Brookings Institution in Washington, D.C. Before coming to Brookings, I spent about 2 years in state government in North Carolina, and before that, 8 years working in the Obama administration on passage and implementation of the Affordable Care Act. So I'm going to be talking about building on the Affordable Care Act to get to universal coverage, how we can get to a system where every American has an insurance card while largely building on the system that we have in place today. So a great place to start is to take a look at how Americans get health insurance today. And as you can see, a little bit more than half of people in this country get coverage from an employer, either their own or a family member's job. Another 17% get coverage through Medicare, the federal program for seniors, and 17% get coverage through Medicaid, the state federal program for low-income folks. 5% buy coverage directly from an insurance company in the individual market. They have private insurance that they get, not through their job, but directly from an insurance company. And 9% of people are uninsured. The Affordable Care Act reduced the number of people who were uninsured by about 40% compared to what it would have been without the ACA, primarily by doing two things. It provided a great deal of new assistance to states to expand the Medicaid program, so a whole bunch of people who otherwise would have been uninsured now have coverage through Medicaid. And it regulated the individual market and provided financial assistance to people buying coverage. And that's what's known as the Marketplace or Covered California here in California. But 9% of people are still uninsured. So where do we go from here? There are sort of three competing visions in American politics right now for what we do next with respect to the pie chart I just showed. The first is a single payer system, like we've been talking about today, something like Senator Sanders' Medicare for All bill or other similar proposals, where every American would get coverage through a single comprehensive national program. We'd scrap the whole pie chart and it would just be one big circle, all the same color. Another vision that has a very different objective is to dramatically reduce the amount of federal money that we spend on supporting insurance coverage today. The idea is that when you look at this pie chart, for some folks, the biggest problem is that we spend way too much federal money supporting various slices of that pie. And so we need to eliminate the Affordable Care Act protections that are providing new dollars to support people getting coverage and change the way we finance Medicaid so that we spend less federal money, even if that means more people become uninsured. A third vision, and one that I want to talk about today, is to target the gaps in the Affordable Care Act, to focus on that 9% of people who are uninsured and figure out how we can bring coverage to those people specifically while leaving things largely unchanged for most of the rest of the pie chart. You can view that either as an alternative to single payer or potentially as a step towards single payer, depending on how you think about the long-term future of healthcare. So how do we do that? Useful to start by thinking about who it is that remains uninsured. Today, 30 million people are uninsured. 57% of them are below 200% of the poverty line. 55% are people of color, and 81% are in working families. So this group is predominantly, but not entirely, the working poor. Another useful way to think about who it is that remains uninsured is to try to think about what slice of that pie chart they might be in if they did get health insurance coverage. And researchers at the Urban Institute have done a great job dividing the uninsured up and trying to understand where it is that they might get coverage and what it is that's keeping them from getting coverage today. And what they find is that about half of people who are uninsured today are eligible for coverage in one of our existing programs but haven't taken it up. And the other half are not eligible for coverage for a variety of reasons. And so we can get to universal coverage by sort of marching down this graph and figuring out how we can remove the obstacle that's keeping people from getting coverage. So let's do that. Let's start with the lowest income group, people earning less than 138% of poverty who should be getting coverage in Medicaid. Right now, one of the things that's keeping this group some people in this group from accessing coverage is the fact that their state has decided not to take the money offered in the Affordable Care Act to provide new coverage in the Medicaid program. And so 9% of folks who are uninsured today are uninsured because their state hasn't expanded Medicaid and they don't have an affordable coverage option. So we need to ensure that Medicaid expansion benefits everyone, either by providing additional financial incentives that are going to prod those remaining states to expand, or by covering the population through a new federal program. So that would make everybody below 138% of poverty eligible for Medicaid. But as we know, some people are uninsured because they're eligible for Medicaid, but not yet enrolled. And so what do we do about that group? A key insight here is to recognize that the Medicaid-eligible population today in most states benefits from Medicaid coverage even when they don't have an insurance card. And that's because for most Medicaid-eligible people, you can sign up for Medicaid at any time during the year. And when you become enrolled in Medicaid, Medicaid will pay your health care bills looking back a couple of months into the past. And so even when you haven't enrolled in Medicaid coverage, you are walking around with a fair amount of financial protection and ultimately access to the healthcare system should you need it. And so preserving that feature of the Medicaid program is a key to getting to universal coverage because it means that large segment of this population has the benefits of insurance even when they haven't proactively gone out and gotten an insurance card. But we should make it easier to enroll in Medicaid coverage by eliminating work reporting requirements that can put administrative burdens in front of people trying to access care and generally making it simpler to access the Medicaid program. So that's the lowest income group. As you move higher up the income ladder for folks who make more than 138% of the poverty line, this group should be getting coverage in the individual market. And so what do we do to bring coverage to this population? The key strategy here is affordability. The Affordable Care Act provides a fair amount of financial assistance to people to buy coverage in the individual market, but it is still expensive. A family of 4 earning $60,000 a year is heavily subsidized, but they still have to pay about $400 a month to get coverage for their family, which is a major burden for a family of limited means. Pair of 60-year-olds earning $70,000 could find themselves paying $1,100 or more for health insurance coverage. And so to bring this group into coverage, we need to reduce the percent of income that everyone at all income levels has to pay to get coverage and make that financial assistance available to everyone in this population. So that makes this group more broadly eligible for coverage, and it makes the coverage more affordable. But even with more generous subsidies, not everyone in this group will enroll because of hassle or administrative burden or the fact that they are churning in and out of coverage as they move between jobs. And so to fully bring universal coverage to this population, we need to give them the same thing that the Medicaid population has, the benefits of an insurance card, even when they haven't made the affirmative decision to enroll. A proposal that I, with my colleagues at Brookings, have been working on is to create something called a backstop insurance plan that would provide that same sort of retroactive coverage to people in the individual market, and then people would be charged at the end of the year for the time that they spent covered in the background by this backstop plan. The last step to get to universal coverage is to address the fact that 16% of the uninsured are undocumented immigrants. So to get to truly universal coverage, we need to either create a pathway to citizenship so that this population has a pathway to coverage once they gain legal status, or broaden the circumstances under which people who are undocumented can access our health insurance programs. So that's how you move down the chart and fill it in and ensure that the remaining population that's uninsured has access to the benefits of insurance. But what are some of the benefits and drawbacks of an approach like this? Perhaps most importantly, An approach like this is designed to minimize disruption for the rest of the pie chart that has health insurance today, particularly the half of Americans who get coverage from an employer. That means they don't have to change anything about the coverage arrangements that they have today, but it also means that a system like this doesn't speak to challenges about affordability or access to the healthcare system that people who have insurance face today. We aren't impacting the household healthcare spending of this group in a system like that. We're really narrowly focused on the uninsured. Some proposals that are similar to what I've talked about today do create options for people who have employer coverage to move away from their employer coverage and buy into a system like what I've been talking about. But nonetheless, a proposal like this has limited impact on Americans who have coverage today, but may still have dissatisfactions with the healthcare system. A proposal along these lines has additional fiscal costs similar to the Affordable Care Act, so it is still a big new federal program and federal expense. It's far cheaper than Medicare for All, but it is a big new investment of federal dollars. It's also worth noting that we are still talking about a patchwork system. We are still going to have a pie chart with a whole bunch of different slices on it, which creates administrative costs across the system and potential gaps in coverage. And finally, I'll note that the tools that I've talked about are how you get to universal coverage, but they don't do anything about healthcare spending and healthcare prices. To tackle the underlying drivers of healthcare costs, we need additional tools. And I'm actually going to hand things over to my colleague, Matt Fiedler, who is going to talk us through some of those approaches. Thanks.
So my name is Matt Fiedler. I'm also a fellow with the USC-Brookings Schaeffer Initiative for Health Policy. Before I came to Brookings, I was the chief economist at the Council of Economic Advisors towards the end of the Obama administration, where I worked on a whole range of health policy issues, but including a lot of ACA implementation. So as Kristin alluded to, I'm going to talk about policy strategies to reduce provider prices. Reducing prices and expanding coverage are conceptually distinct policy objectives, but in practice, many approaches to achieve universal coverage also include policies targeted at reducing prices, in part because reducing prices can be one strategy for, at least in part, financing a coverage expansion. So I think most of this audience, this will be very familiar for, but just to fix ideas, when we talk about healthcare spending, we can break it into two components: utilization, how many hospital visits, office visits, diagnostic tests, et cetera, people receive in the year, and unit prices, how much we pay per service. So I'm going to be focusing on this second piece here, and particularly in the context of private health insurance, which is not to say that there aren't lots of interesting things to be asked with respect to utilization. There's a lot of interesting policy questions here, but I'm going to focus on the prices piece. So in thinking about how policymakers might approach this area, I think the first important question is to ask, what are we aiming for? So this is a complex question to answer in general, but I think roughly speaking, the goal should be for prices to be high enough to ensure that providers have the resources they need to provide care of an appropriate quality, but no higher. And there are obviously negative effects if we miss in either direction. Excessive prices most directly create a financial burden for the people paying for care, whether that be households who pay their premiums or pay for care out of pocket, or the government, since the government, even for people who receive coverage through an employer, pays a substantial portion of the healthcare bill. Higher prices can also discourage appropriate use of care, and providers' ability to elicit high prices reduces the financial pressure they face, which may in turn reduce the effort they invest in becoming more efficient. Now, the flip side of that is we can also absolutely have prices that are too low. And the prices that are too low may not provide revenues sufficient for providers to cover their costs, leading them to exit the market and threatening access to care. It may also lead them to make cutbacks in their spending that in various ways threaten the quality of care. So there's a delicate balance to strike here. Now, I think there's general consensus that the prices that are paid in private insurance are, at least in general, too high. And I think there are basically two types of evidence that people appeal to make that argument. One is to compare what private insurers pay for care in different parts of the United States. So what I'm showing you here is the average price of a hospital admission in different parts of the country based on work by a team of researchers using data for 3 large national insurers. And what you can see is that there's very wide variation across the country in the average price of a hospital admission, from the sort of lightest blue areas to the darkest blue areas. If you took the sort of average admission in each of those buckets, you're talking about roughly a factor of 2. So this is very wide variation. That leads naturally to an assumption that a view that there might be a lot of money to be saved if we could make the entire country look more like the light blue areas and less like the dark blue areas. Obviously, there may be other things that differ between the dark blue areas and the light blue areas. We might think that the dark blue areas have higher prices because the providers in those markets are delivering higher quality care and incurring higher costs to do that. And there's probably at least a little bit of truth to that. But it's probably not enough to account for the very wide variation in prices we see in practice. So the other data point that often comes up in this area is to compare the prices paid by different types of payers within the US healthcare system. So what I'm showing you here is the average price paid by private insurers as a percentage of what Medicare pays for the same services for 3 broad categories of services. And what we can see is that private insurers pay substantially more than Medicare does, and that's particularly true for hospital services. At the same time, we know that beneficiary access to care in Medicare is quite robust, which suggests that Medicare prices are indeed adequate, at least to meet our access goals. Now, one might be concerned that those Medicare prices, cover hospitals' marginal costs of treating patients, but maybe they don't cover their fixed costs of treating patients. And again, I think there's probably some truth to that argument, but the magnitude of those fixed costs are probably not large enough to justify the very large prices we see, very high prices we see on the private side of the market. So if we accept the premise that prices are very high, why do we think that is? And I think there are 3 basic explanations that drive this. One is that many healthcare markets, competition is fairly limited. So the typical hospital admission in the United States occurs at a hospital with about 2 competitors, on average, with 2 competitors in a 15-mile radius, which is a fairly concentrated market and is one that when insurers go to negotiate with providers, they recognize that if they don't strike a contract with this hospital, they don't have too many other options to negotiate with. And that gives providers substantial leverage to extract high prices. I think the other important component of this that interacts with that limited competition, however, is that consumers in practice appear to place a very high preference on having broad choice of providers. And so that leads you into a situation where if there were 2 hospitals in town and consumers basically viewed those 2 hospitals as equivalent, the insurer might still have substantial leverage to extract a lower price from one of those hospitals by threatening that, if you don't give me the price that I want, I won't cover you and I'll send all my enrollees to the other hospital. In the world we have where consumers are very particular about which hospital they want to go to, that insurer is going to recognize that in many cases dropping a provider is going to render its insurance offering unmarketable, which in turn gives the provider very substantial leverage to extract a high price. And then I think the third component of this is that there are some public policies that I think have the effect of limiting insurer leverage that I'll talk a little bit more on in a moment. So if we were to tackle, if we wanted to reduce high provider prices, what would our strategies be? So I think you can think about these strategies in 2 broad buckets. One is focused on trying to make market competition work better. And so I think there are a variety of policies that would go towards that objective, but I think there are 3 big ones. So one would be stronger antitrust enforcement, aimed both at preventing mergers that lead towards markets becoming concentrated and the creation of market power, and also at restricting the ability of market actors that have already accrued substantial market share and market power from using that market power to extract high prices. Concretely, that probably means greater funding for antitrust agencies. to run the appropriate investigations and bring enforcement actions when warranted. It may also mean additional legal authorities, both in terms of what sorts of actors they're able to oversee and potentially the sort of burden of proof they're required to meet in some circumstances. I think the second prong is reforming some of the policies, public policies that lead to high prices. So one example would be the tax exclusion for employer-provided coverage. The way our tax system works, if you get an additional dollar from your employer in the form of health insurance, you do not pay income or payroll taxes on that amount, but you, if you receive the same dollar in wages, you do pay income and payroll taxes, which has the effect of meaning that the federal government is providing a subsidy equivalent about 30 to 35 cents on the dollar for each dollar spent on healthcare. That likely makes consumers willing to pay more for healthcare, something that providers are then able to extract in the form of higher prices. A third strategy would be to make price shopping easier. So where we do have competition, make it easier for consumers to compare prices and go to a lower price provider. I'm frankly moderately skeptical on how large an effect this could have, and if not done carefully, there's a potential for this sort of strategy to have some unintended consequences. But it is a policy that's generally discussed under this heading. So I think most or all of these things are things that policymakers can and should do. I think there is a very open question particularly where we already have very concentrated markets and where it may not be realistic to expect that we're going to have a large number of providers serving a market, whether these strategies are going to be sufficient to get prices to the level they should be at. And so I think there is policy interest right now in approaches that would make greater use of what's sometimes called administered pricing, where the government in one way or another would get more involved in directly setting the prices of healthcare services. And I think those approaches fall under two broad buckets. One is is price regulation of one form or another. You could imagine directly regulating the prices that are paid from insurers to providers. One could also imagine approaches that would limit those prices in a defined set of circumstances. So for example, only when people go out of network for care. That second set of policies would the out-of-network cap approach would reduce prices in some instances, but not others, but is one approach that's often discussed. I think the other approach, which is particularly getting a lot of attention in the context of the Democratic primary right now, is to make greater reliance on public insurance programs. So you see that in proposals to create what's often called a public option, a public program that would be people could buy into in lieu of buying private insurance. And I think the final approach, which is a more radical approach, would be to eliminate all existing insurance programs and shift everyone into a single payer system that would pay prices more like what Medicare pays today. I think whichever of these approaches we pursue, the bottom line is that we need to remember the trade-off we were thinking about earlier. I think we've got good reason to believe that the prices we're paying right now are too high, but there absolutely is a potential to be too aggressive in how we use any of these approaches, particularly the administered pricing approaches. We need to be cautious not to use them too aggressively, and that's going to be, I think, the big challenge that policymakers are going to face going forward. So, hand it off to Lauren to focus on one particular instance where the prices are high.
My name is Lauren Adler. Similar theme, I'm Associate Director of the USC-Brookings Schaeffer Initiative, housed at the Brookings Institution in DC. I don't have fewer jobs in the past to really point to, so I've mostly just been at other think tanks doing research for the last 10 years or so. As I think Matt alluded to, I'm here to kind of talk to a narrower section of healthcare policy that somewhat combines sort of a surprise billing, which has been in the news recently, that sort of combines a failure of the coverage that we have today, sort of underinsurance to some degree, and also an area where I think it is very clear that prices are too high. It's not just hospitals. This is a little bit more physician-based, where we're looking at, I think, one of the more clear abuses, as I would call it, in our system, or failures of our system. I think so. Some people in the room may have heard of this as sort of the thing moving in Congress right now, to some degree, other than impeachment. But It's called surprise out-of-network billing, and just to define what this is briefly, I think a lot of people would call almost any bill you get in healthcare as a surprise. Here we're kind of really referencing two specific scenarios here. So one is, in any emergency situation, you're rushed to a hospital, the ambulance that took you there. Turned out it wasn't in your insurer's network. Insurer pays something. The ambulance can then bill you for the difference between their sort of made-up list price and whatever the insurer paid. Those list prices tend to be extremely high and have no bearing to any sort of market price, and the patient is stuck with the bill. You can also be in the situation where you are going to, you sort of do everything right. You go to an in-network hospital, you schedule a surgery. The surgeon, you made sure to check that the surgeon was in your insurance company's network, but it turned out the anesthesiologist, who knocked you out for the surgery, wasn't in network and, leaves a bill on your chest when you leave. So these are sort of the we're not gonna, all right, click. Just to kind of point out, this is not, I think we hear a lot of anecdotes. There's been a lot of great reporting on where this is sort of more of a problem. It's more than a series of anecdotes here. This really is pretty common. I think this chart here, we're just trying to show, this is 1 in 5 times someone goes to the emergency department, they are going to be seen by an out-of-network physician as part of that care and potentially get a surprise bill. And about 1 in 10 times in that second scenario where you did everything right, you scheduled a surgery with an in-network surgeon, 1 in 10 times there still the anesthesiologist or the radiologist, read your MRI, is going to be out of network and can potentially hit you with a pretty large bill. That really wasn't what you signed up for. When you signed up for insurance, part of that was supposed to be that it was going to cover costs like that. I think what gets lost sometimes in this debate is that this also isn't just a, random, crazy things happen in the healthcare system. This really represents strategic behavior, at least by a subset of providers here. There are these specific types of physicians and specialties who have this ability that patients do not choose. So there's only a few, most physicians, right? You go to a cardiologist or a neurologist, you're sort of making an active choice to go to that doctor. You're not going to go to an out-of-network neurologist. But when the anesthesiologist or the pathologist or the emergency physician, who you have no choice over which one actually sees you, you're sort of left in this sort of bind here, where they basically get to bill you what they want. And not surprisingly, we see that those types of physicians bill significantly higher amounts of money relative to what Medicare pays than any other type of specialty. So, there are 20% of anesthesiologists in the country basically who are billing more than 11 times what Medicare pays for that service. And that's just something you don't see. If you looked at every specialty who's sort of bunched in that all other specialties here, you'll never see another one like that other than the ones patients don't choose. And then beyond that, it's not just that these people are billing very large sums of money, is that they are then using that as leverage with insurance companies to get paid more money even when they do go in network. So often, most anesthesiologists or emergency physicians are in an insurer's network, but particularly the large companies, the large staffing companies that operate in this area, are very clearly threatening, I will surprise bill every one of your enrollees who walks through the door unless you pay me a lot of money. And not surprisingly, they get paid a lot of money. So he is here, right, showing that these types of physicians really are getting paid 2, 3, 4 times the Medicare rate, whereas pretty much every other physician, is on Matt's slide as well, is somewhere in the sort of 1.25 to 1.5 times what Medicare pays. And this is expensive. So we all pay for high provider prices. We all pay for that through premiums. Estimates out there basically peg it at we're all paying potentially, if these physicians were paid like other ones relative to Medicare, premiums would be about 5% lower. So it is certainly a narrow sect here of the healthcare market, but I do think the effects are somewhat large. I will very quickly, I think the solution stuff is probably a little tough to go into here. I'll mostly skip through this, but I think to mostly point at the most logical solution to this is simply to make it so there is no such thing as seeing an out-of-network anesthesiologist at an in-network hospital. That's completely illogical to any normal consumer or any normal patient. That should just be illegal. That shouldn't be a thing that's allowed. There's multiple ways to do that, but you don't get seen by an out-of-network nurse, right? That's not a thing that happens. The hospital makes sure that the nurses who work at their facility, obviously a very important part of your care, but you're not getting a separate bill from them. Honestly, that's basically what is here, is that shouldn't be a thing that anesthesiologists can do. I'll actually just sort of leave it there, and I think we can jump onto the panel, which I think we need more seats for.
I'd like to, we'll have a broad conversation and then we'll open it up to the audience. But I'd like to begin with asking some questions. And thank you for your provocative presentations. I want to follow up on some of the things the Attorney General said. The first is, Kristin, you noted that maybe 9% of people are uninsured. In some states, the rate is 3 to 4%. In Texas, it's 17%. And I'd like to know, when we talk about homelessness, housing is a basic right. Most people would agree to that, but we allow states and actually localities to make a lot of the determinations. And similarly, when we talk about education, there's a very limited role for federal policy. We have a lot of states that have chosen different paths in how they use the ACA, and in particular, the Medicaid expansion. Why is this a federal issue?
So health policy has to be a federal issue because it is so expensive to provide health care for people. You alluded to this in your opening remarks. Health insurance for a family now costs $20,000 a year. A single adult health insurance, just the insurance, not counting their cost sharing, is about $7,000 a year. This is a major expense. And states don't have the resources to provide that level of the level of assistance that's necessary to make healthcare affordable for people. And importantly, states don't have the ability to run budget deficits. So people's need for financial assistance and affording their healthcare grows during recessions. And if states were on the hook for the entirety of the spending, you would put states in a tremendous bind every time a recession hit. Our system today already does that to some extent, but without federal involvement, things would be far worse. So fundamentally, you need the federal government involved in order to make healthcare affordable because it is just so expensive.
And also, I'm going to say names, but feel free to jump in. This is your opportunity. But Matt, you framed it, and thank you for your economics lessons. Spending is price times quantity. Sometimes people forget that. And actually, the point of your talk is Medicare, the government has control over price, and we can regulate prices, and that's one way to do it. If you look at the work by Seth Seabury, who's a professor here in the Schaeffer Center, he's shown that when you look at private plans, for example, they pay more in price, but they also do a better job controlling quantity. And actually, if you look at Medicare, one of the reasons people think it's not a government-run program is because there are very little controls, actually, on utilization. And so it turns out regionally, Q varies quite a bit more in Medicare. And a lot of that, some of that is actual outright fraud, by the way, which costs about 50 to 70 billion and would not be tolerated by a private plan. But a lot of that is in some ways more pernicious in that it's waste and it's services that we know don't do a lot of good. And so my question is, if you ask, and I'm getting to it, if you ask how prices are set in Medicare, you'd say, are they using value-based prices or doing anything that makes sense in a market way? But really, what they seem to be doing is basing prices on how many hours it takes a physician to complete a task interacted with how much political clout that physician group has. And so my question to you is it really a solution here to allow for regulated prices, given the way this has been implemented in Medicare?
So I think one of the premises of your question fundamentally is that I think it is true that private insurers do a better job of managing utilization. I think one of the premises of your question is that private payers do a dramatically better job in setting relative prices, which frankly, I think the evidence isn't clear on that. And for the most part, what we see is private payers actually piggybacking on Medicare's fee schedules and how they set relative prices to a very great extent. So in many cases, About half of hospital contracts, what they look like is they've taken the Medicare hospital fee schedule and they've multiplied it by some number. And so how much value are private payers really adding there? I do think there is value, and I ultimately tend to find the public option type model attractive because I think that is a structure where I think introducing a public plan can put real pressure on unit prices, but it still creates a space for private plans that are very efficient at utilization to gobble up the public plan's market share in instances where the private plan really is adding value. And I think to develop strategies that, over the long run, the public plan can adopt if they're useful. So I think I do see some advantages to a sort of multi-payer pluralistic system in that regard, but I think probably both play a role. I think it's interesting in Medicare Advantage, we've seen that work very well, where the private Medicare Advantage plans get prices basically that are very similar to what traditional Medicare does, but they've also been able to be very effective in managing utilization. Unfortunately, because of the way we pay Medicare Advantage plans, the federal government hasn't captured much of that savings, but at least in principle, there are savings there to be captured.
But I think that's an important point. And actually, if you look in the commercial market, there is evidence that we pay more and it's higher quality. It's when you get into Medicare where we don't see that. And so there is some signal being presented. Now, we know that obviously, as you said, market power has a lot to do with price.
Yeah, and I don't want to argue that. I think it is clear there is some cross-sectional correlation between quality and price. I think in a well-functioning market, we'd want to know that the difference in price is commensurate with the additional cost required to deliver that additional quality, and I'm skeptical that that's the case in practice.
Right. Okay, well, some of the evidence is longitudinal. John Romley has shown that. But Lauren, I thought it was very interesting. I think your work with your colleagues on surprise billing has had enormous impact, and there's legislation pending, and you should be congratulated for that. But I think I want to push you a little bit because there's an opportunity that maybe this provides an answer to a broader question. What kind of the policy remedy you're suggesting is one where we need a backstop. But the market, you're not talking about regulating all prices for anesthesiologists. You're just saying we want to make sure there's coverage and the private market is setting a price and we're not leaving consumers insured. Is there anything we want to take away from that about what your position might be on universal coverage, or am I pushing it too far?
I think it's tough to probably push them slightly too far, but
that's my job.
Yes, no. Probably should start out. I should have thanked my collaborators in all this work, including Aaron Trish and Aaron Duffy, who are in the audience and work here with you at USC. So I think this is sort of. I would count this more in the package of Matt's first bucket of. Let's try to make the current, if your goal is make the current market work as well as possible, I think tackling something like surprise billing is important. I think that's sort of an area where there's a clear market failure, and I think you can group in certain areas where there is sort of clear excess market power in hospital markets into a similar bucket here. But the policies that I think we're talking about I wouldn't say they are really sort of setting prices here. They're very much sort of just taking away the sort of excess leverage that exists from market failure. But I'd probably put it more in the bucket of, there's multiple approaches. And I think everything you're talking about, or that is being talked about by Congress in the surprise billing context, really isn't actually, really regulating prices. If you really wanted to save a lot of money and wanted to do something like Medicare for All or something like that, that would be you can save a lot more money, but it would be just a sort of broader undertaking. That's why I kind of think it's somewhat of a narrow issue in that sense.
Well, it's interesting. We never hear Medicaid for all. Medicaid's even cheaper, but I don't hear anyone arguing for that.
Fine chats is fine.
I want to, the Attorney General brought up also Part D, and he talked about the success of getting seniors coverage. That happened earlier in this century, about 40 years after the introduction of Medicare. And yet, it turns out that prescription drugs are some of the most effective tools we have for managing chronic disease, which has a lot to do with the projections of the $50 trillion potential deficit in Medicare. So it took 40 years for Medicare to innovate to get a prescription drug benefit to cover the stuff that actually works. Is that a cautionary tale for Medicare for All? I'm opening that one up to all of you.
So I'm happy to take that one first. I mean, one of the reasons, we talked about sort of the potential for private innovation utilization management or maybe improving pricing structures. I do think there's also potential for private innovation in benefit design and other dimensions, consumer-facing dimensions. And so from my perspective, that is one of the real advantages of a multi-payer system, that you can have public payers potentially doing what they do well, which is checking market power, and private payers doing what they do well. And I think there's a potential for that to be synergistic. I think the real downside is what Kristin alluded to, is that with multiple payers does come substantial administrative cost. And so the question is, how do we weigh those administrative costs against that innovative potential? I think I come down on the side of thinking the innovative potential makes it worthwhile. But there is a real trade-off there that I think is hard to evaluate.
And I'll just add, I don't think anyone on this stage would say that innovative potential is worth 9% of people being uninsured. We are talking about sort of variations on how you get to universal coverage, but none of that speaks to, we don't need a system that has these tremendous gaps that people can fall through to continue to have the kind of pluralism and innovation that Matt's talking about.
Yeah. Drug coverage is also one of these things that people, government knew that was something we need. I mean, the Blues plans had that, 20 years before. It was pretty common. But I mean, I think we all knew that was something to do. That was more of almost a political problem. But I do agree. I think there's also things. So I think almost broader Medicare Advantage has, shown that there's a lot of waste in post-acute care or something like that. Where I think is useful, where I think where a public program could then, hopefully, eventually, I mean, right, we've known there's sort of a lot of that in post-acute care and Medicare for, 15 years are going on at this point. Clearly, political process isn't the fastest thing.
Right, and I think the concern that the political process could get stuck and a public plan could get stuck in a suboptimal set of policies is a real one, and a reason to think that some public-private competition here could be healthy.
Yeah.
So is there anyone here who supports single payer with government set prices, no private plan option in the marketplace? Which is kind of what I heard from the Attorney General, although.
I won't go all the way to saying I support it. I will say I see the appeal.
You don't want to raise I want hands raised. Okay.
This is a debate,
We have an incredibly complex system today that imposes significant financial burdens on a lot of people, even when they have insurance. And we can continue to make policy that tackles each of those challenges one by one. And that's what I laid out, and that's what Lauren was talking about when it came to surprise billing. Like, there are steps we can take to continue to make things better for folks. But sometimes I certainly understand the impulse to step back and say, this is nuts. What are we doing? It shouldn't be like this. And I think that is the impulse that underlies a lot of the enthusiasm for single payer. That said, I don't think any of that is inconsistent with the sort of the impulse that we are talking about making incremental progress to make the system better. Like, one can be both excited about big sweeping change that gets rid of a lot of things that are complicated, and also be excited about incremental change that would make the system work better in narrow ways for a lot of people.
Right. Okay.
I mean, it also sounded like the Attorney General at times was picturing something that looks much more like the current Medicare program.
I don't want to mischaracterize what he's thank you.
Where that's
I mean, I think Ed Kleinbard pointed out the 120-page description of Medicare. It is a little confusing. I helped my mother with it. But okay, I think what I'd like to do is ask you, so let's assume that there is some role for private insurers, private providers in the future of health reform. If you look back at the ACA, the healthcare industry supported it, and I think it had a lot to do with its passage. how likely do you think these various constituencies are to support the next generation of reform?
Want to kick it off, Matt?
Zero.
So, I mean, I think it depends on which set of the proposals. I actually think the set of proposals that Kristin was talking about will have fairly broad appeal among both providers and insurers, right? They mean more customers in the course of ensuring that people are financially protected and have access to care. I think as you start to think about prices, your coalition gets narrower. So, obviously lower prices for providers is somebody's income. It either means, disruption of some kind, and it means disruption of some kind. So I do think those approaches are going to be challenging. I think one question is what the overall package looks like, right? If you look back at the ACA, it wasn't the case that there were no provider cuts in the ACA. The ACA had big cuts to hospital payment rates and substantial cuts to Medicare Advantage reimbursement rates. And I think the industry, for the most part, said, I'm getting enough in the form of expanded coverage and new customers that I'll tolerate the cuts on the other side. And so, if there were major healthcare legislation being discussed in 2021, I would not be surprised to see that sort of equilibrium reached where the industry says, I may not love every piece of this, but I can live with the overall package. That's often what legislating looks like.
Can I sound?
Oh, yes, please.
Sound a note of pessimism to Matt's optimism, which is not usually the way we talk. Lauren outlined the surprise billing problem, which I think we all, those of us who work on it at Brookings, think is like a real abuse of power. It is people exploiting a market failure. And yet in Congress trying to make progress on this issue, you have seen the provider industries fighting tooth and nail. When you listen to Spotify in Washington, D.C., you hear advertisements from healthcare providers fighting surprise billing legislation. I don't know if that's just a D.C. thing or if you get it out here too. But the provider community has really dug in and fought hard against even sort of a set of very common sense and easy to explain and easy to justify policies. And so I think that's something to keep in mind as you sort of think about what comes next.
So one of the names that got mentioned more than anyone's today was Tom Prisalak, who's here. So we're going to open it up to audience questions.
I was on a committee for the Institute of Medicine, 10 or 15 years ago, and one of the things that we recommended was that by the year 2030 is coming up, that the United States should be average among rich countries in these two dimensions. One is how much we spend on healthcare, and the others are health outcomes. And we just looked at this again, and it turns out that in terms of health outcomes, we continue to decline more rapidly than any other rich country. We're now 60th, actually, in the most recent global burden of disease analysis. And what strikes me is that, and by the way, and cost continues to go in the wrong direction. But we've had a bunch of these great ideas for controlling volume. That we had choosing wisely, we had utilization management, we had ACOs. But despite all that stuff, we continue to get worse. And I was just curious, in a fee-for-service-based system, can we really get there?
Wow, I want to answer, but I guess I'm moderator.
Welcome to it.
Well, I'll start. I'm going to jump in. We developed our system. Every actor in our system responds to incentives. And the way we originally designed the healthcare system is we paid fee for service, and that rewards volume. And we got a lot of volume of care as a result of that. I think the real question is if we figured out how to reimburse for health outcomes rather than health inputs, would we get to some of the objectives you're talking about faster? And my own personal concern is that we haven't given that enough of a shot. And actually, you look at Kaiser, for example, they spend a lot more on prevention because they have people in their system longer and they're rewarded as, again, the Attorney General pointed out, for keeping people out of the hospital. So, but you may want to respond differently to that.
So, I'm also generally optimistic about changing the way we pay for care. I don't think the experiments we've had so far have been overwhelmingly successful, but I think they've moved us sort of modestly in the right direction. Do I think they are probably going to be the main strategy if your interest is in closing the gap between the United States and other countries' health outcomes? I'm not convinced that the healthcare payment system has very much to do with that. I mean, the other countries don't know how to do this paying for health outcomes either, because we don't really know how to measure the outcomes we want to pay for the most part. I think that is probably likely to have more to do in some cases with things outside the healthcare system, and in other cases with at least ensuring, universal access to some degree.
And I would just add that I think any serious conversation about improving health outcomes needs to grapple with serious disparities in our outcomes, both by income, but also by race. If you look at maternal mortality, Black women die in childbirth at a rate that is 3 times the rate at which white women die. And serious conversations about how we improve outcomes need to grapple with those disparities, which frankly, we don't really understand the cause of today, and we need to spend a lot more time thinking about why those disparities exist and how we can solve them.
And thank you to Alice Chen of the Price School for pointing out some of that. So.
To address the last question regarding the wealthiest nation in the world and ranked 16, if you look at the states per capita GDP and look at life expectancy, that says something. California is one of the richest states in the country. Our life expectancy is 82 compared to Alabama, which is the poorest state in the country. Life expectancy is 56, 57. So when you're looking at these, 76, it's 5 years less.
I was like, that's really low.
If you look at that, is there been when you're in your analysis and you're looking at things and going back to social determinants and what you said about vulnerable populations, lack of education, lack of housing, that kind of thing. How does that factor into the overall equation?
So Victor Fuchs has a the father of health economics, if you will, has a classic paper where he compared outcomes between Utah and Nevada in terms of life expectancy. He pointed out the healthcare systems were very similar, but there was a 10-year difference in life expectancy. And it turned out people in Nevada, they get divorced, they drink, they gamble, they smoke more. And people in Utah, they don't. And look at how well Mitt Romney's doing. And so, the point is that if we really were concerned about health, maybe we should be having a discussion, should we be investing in education, not health insurance?
So, I think it's certainly possible that it would be investments outside the healthcare system. I'm frankly skeptical that in some of these cases, I suspect, some of these supportive housing or education or whatever interventions probably do have returns for health. Whether the lion's share of those returns are actually to those sorts of interventions, right? The main intervention of an anti-homelessness intervention is the person has a roof over their head. My suspicion is, the health is a nice bonus, but if you sort of tally up the total benefits of that intervention, most of those benefits of that intervention are in the domain where the intervention occurs. So I think the attention to social determinants of health is really valuable. I think thinking that we're going to do these things and the main thing we should be looking at is the health outcomes we get from them may lead us to make some sort of bad choices where we have potentially interventions that are very valuable. It's just, only 25 cents on the dollar is better health.
I guess one of the things that the Attorney General mentioned that kind of got my ire up is this thing about you have a kid who has a problem. You want absolutely the best thing, no matter what the cost is for the kid. And I totally, having kids, I totally agree. But on the other hand, who thinks about population health? Who thinks about how we allocate our resources in a way that we're able to fund the care for all the kids out there, all the vaccinations, et cetera? And we already know we love to pay for old people dying. And where is the infrastructure to try to put into place this view of taking care of everyone in the United States? And it includes all of your suggestions. But one of the things that I read was a critique or a comment on what they did in Massachusetts to try to afford their experiment. And it did involve a sort of separate route saying, this is cost containment. This is what we're willing to pay. This is how we're able to spread the wealth across the population. I think we have to have that as part of our healthcare system.
Yeah, and Massachusetts also benefited from a $4 billion injection of federal money, but that gets to your other point. Problem is, that's a zero-sum game, but anyone want to?
I mean, I think largely this is the impetus for, I think, the universal coverage stuff that we've all been talking about here, at least in the scheme of getting so that everyone sort of has access to at least quality coverage. But I think what you raise is the key reason that, in my mind anyway, you would really want to couple that with the stuff that Matt was talking about in terms of cost containment. And right, Massachusetts says, they're often not, it's not like you can do it focused on the quantity side, right? And other countries certainly have, we'll cover some things, for elective procedures, you're gonna have to wait longer and that sort of thing, or low value care, you're gonna have to wait longer and someone's sort of making that decision. On the flip side, right, it's not exact, there's no like magic number of how much of our GDP we can sort of like allocate to healthcare here. We allocate a boatload in this country.
That's a technical term.
Yes, but I don't know that there's, I think there's enough fat in the system effectively that you can at least start trying to couple where you're kind of moving to universal coverage with the cost savings. I think my fear probably is that the universal coverage move, in order to get industry support, is that the universal coverage move that actually happens will be, okay, here's 250% of Medicare rates for everyone. It's going to cost some more money, but at least everyone's covered. I think that's where we kind of get into that danger of, at some point, that becomes probably untenable.
Right. I think the interesting thing is the last major federal healthcare legislation we had did not follow that model, though. It financed itself, roughly half out of the hides of providers, roughly half of the coverage expansion financed out of the hides of the providers, and roughly half out of new tax revenue. And so, I think my view of the federal political economy, which I think is somewhat different than what happened in Massachusetts, is that coverage expansion is probably the sugar that makes at least some of the medicine go down on the provider side.
Okay, I think we're going to have to leave it there. I really want to thank our Brookings Schaeffer Initiative USC colleagues for coming and taking the time and doing this. And now I want to introduce the Dean of the Price School of Public Policy, Jack Knott, who's going to summarize.
Well, thank you, Dana, and all the participants. Let's give them one more round of applause. It was really fantastic. This has really been a significant afternoon, tackling one of the most important national challenges that, as was pointed out, we've been trying to solve for over 100 years. And I remember that from my history that Teddy Roosevelt actually tried to introduce legislation for universal coverage. The Price School is turned 90 years old this year, so this issue has been around longer than we have. And wasn't solved in the progressive era, as were many other reforms during that period. It was one that wasn't. From my point of view, this is partly an issue of values. There are trade-offs between having universal coverage and the kind of system we have today. My wife is from Britain. They do have universal coverage. They don't have they have a single payer, but they also have a public system. And it's quite clear that you wait a lot longer if you want to have knee surgery. There's a whole lot of queues. They don't pay as much for things at the end of life. It's much more spread around. And they spend about half of their GDP as we do. Now, it's the case that if they would increase that to 18% like we do, they could cover all those things. But what I think happens when you get a global budget, which is what they have, and most other countries, as was pointed out, do have global budgets. They only spend so much. You have to make these kind of trade-offs, and that's what Britain does. And it's a little bit to me like. When we shifted in California from local tax, property tax, to paying for schools and education by the state government, sales tax, We spent a lot more on schools when it was local. Each community could decide, rich communities could say, gee, we want to spend a great deal on education. Now, that's not the case because there's a state global budget on education, and we are now below the national average in what we spend on schools. And so those are the kind of values that we're grappling with. Do we want to allocate healthcare by price, or do we want to allocate it by queue and sort of administrative process and a political process? If you have values that you really care a lot that kids and families, and no matter where they live or how poor they are, they get a basic health care, that's one value. If you have another value, like many of the wealthier people, say, supporting USC, who want to get as much health care as possible, and they're willing to pay for it. And even if they're going to extend their life 6 months, they're willing to spend $5 million or more on that. That's another kind of value, and that's the kind of value we have. So this is a very fundamental thing, and the reason it's so hard to solve is because these values conflict in our society, and we haven't been able to bring consensus around what these values should be. So I think this is a very, very important discussion. I was really thankful for hearing the Attorney General, as well as our expert panel, talk about the various alternatives. The more bold alternative of going to a single payer versus ways of filling the gaps that we have in the current system. And it's particularly hard for our society to go to this bold alternative because we already have a very complex system with all these different payers and companies, et cetera. It's not like we're starting from scratch and we can just do it. And so there's a lot of appeal to filling in the gaps rather than throwing away a lot of what we have, which is terrific compared to that if we had to start from scratch. But I thought the discussion really very nicely went from that very bold option to the specific kinds of things that we could do, including just controlling prices. So I really benefit from that, and I hope all of you did as well. I really want to thank the Attorney General for coming. Obviously a very busy schedule, especially now, given all the lawsuits going on. I want to thank Mr. Schaeffer in particular for his tremendous support of the Schaeffer Center, but also this Brookings Schaeffer partnership. This is a really valuable thing. It really combines outstanding research expertise here at the university with also the research expertise at Brookings, but also with Brookings' tremendous ability to get these ideas and this expertise out into the policy arena and into society. And that's really is what we want to do as a university. We want to obviously publish in the best journals, but we also want to make an impact on society. And partnering with Brookings is allowing us to do that in a way that we otherwise wouldn't be able to do. And I want to thank the partner with the Price School with the Schaeffer Center, which is the USC School of Pharmacy. This has been a great collaboration for us. I don't know if there's another school in the country that combines pharmacy with policy in such a unique, special way. And given the aging of the baby boom and the importance of pharmaceuticals to chronic care, as Dana pointed out, I think this is just the right combination. So I'm really thankful for that as well. I value the opportunity to bring together those on the front lines in Washington. And you can, we wish we were a little more in Washington as a school as well. But like our Schaeffer Initiative colleagues who regularly interact with the leaders on Capitol Hill, our Attorney General who is advancing California and stands in many ways as much of what California does as a model for the rest of the nation. And of course, our own Schaeffer Center experts at the Price School and the School of Pharmacy, whose work really informs health policies, and we hope health policy reform that leads us much closer and actually achieves universal coverage for us in the future. So thank you all for joining us, and hope you enjoy the conversation. Have a good afternoon.